Good afternoon, everyone. My name's Fiona Gray and I'm the Medical Subacute and Palliative Care Program Director for Mercy Health Services. So today I'm going to talk to you about the work we've been doing over the last year. First of all, I'd like to acknowledge the Aboriginal and Torres Strait Islanders and pay my respects to the elders past, present and emerging. So Mercy Hospitals Victoria is a component of Mercy Health. In Mercy Hospitals Victoria, we have two main facilities. The Mercy Hospital for Women, which is a tertiary referral centre for women's and children's care, and it houses one of the state's neonatal services. They have an emergency department. The emergency department is focused on women's and children's. They do see some neonates, but it's primarily obstetrics and oncology, gynae-oncology and gynae patients. The Werribee Mercy Hospital is a growing hospital in the outer suburbs of Melbourne at Werribee. The patient population is very general and we're in a very rapid growth area, one of the fastest growing municipalities in Australia, definitely in Victoria, and we have a mix with mental health, general patients, obstetrics, goodness me, and lots of others. Bits and pieces. Our emergency department there is experiencing quite a significant growth, and over the last few years we've been growing year on year. This past financial year there was greater than 40,000 presentations. So over the winter strategy we had a lot of plans in place and they fitted into the four main themes of patient flow and access, immunisation, infection prevention and primary care interface. So with each of these there were quite a significant number of actions we were going to take should we need to. A lot of these, the surge preparation and capacity, the work around what to do with our pandemic working party, it all became part of business as usual as we went through winter and we didn't experience the demand that we were expecting. There were a couple of key activities that for us were more around managing our capacity ongoing as opposed to just for winter demand. So we were looking at it from the perspective that if we improved what we were doing on a day-to-day, it would make us more prepared for when we hit a winter demand or any other demand actually. So I'm mainly going to talk moving forward about Werribee Mercy because Mercy Hospital for Women have been in a stable status and their performance and their NEAT etc. has not really changed over the last few years and they have strategies in place to work on that. However, Werribee Mercy is an entirely different story where we have been really under the pump there. So I thought I'd put these slides up to remind us what this year's winter did look like. It didn't work out to be as much of a demand, particularly as 2017 was for us all. But from our perspective, it wasn't the winter that we were most worried about, it was the other things that were going on for our facility down at Werribee. So this gives you a little bit of a picture of what our activity looks like in the emergency department of Werribee. So the last 3 years, the first graph, shows the year-on-year increase in presentations where we've gone from around under 35 to 37 to over 40, getting close to 41,000 patients per year. In particular, this winter, the shift from the last quarter of the last financial year to the first quarter of this financial year, you can see the change there, where our presentations on a daily basis have gone from averaging around the 120 to somewhere up around the 150 over the winter months. The AV arrivals also, we put in a little bit of work earlier in the year and we had an increase in our offload times. And we were doing really well, and then we started to get a lot more ambulances. And because we were doing so well and we were getting them back on the road, they were preferentially coming to us. Didn't help us. In terms of what else was going on for us down at Werribee, it wasn't just what patients were walking through the door. We had a lot of competing demands that were making us being able to provide the care the way we wanted to a little bit more challenging. So first of all, we decided that we had put in a submission to change our triage area from an health and violence perspective, because our triage had been a standalone triage area and not really connected to the emergency department, which was problematic. So we were successful in getting funding, which was great, and by the time we started works, we were into winter. So we had a building site within the emergency department for the triage, a new bar room, our waiting area and our fast track area were all being redesigned over the period of about May through to about end of July. We also were part of the Victorian Stroke Telemedicine project. We were the first metro hospital to become engaged with this. So because we didn't have stroke services on site, it was how we could get prompt assessment and action for our patients who came to us, and also for inpatients when there was a suspected stroke. So this has been a great initiative, but it was a fairly significant change process going on for the staff in the emergency department. We received some extra funding at the beginning of the year, or in about April, which was really positive, and it was a really good kick for our staff that the busyness was being recognised and we could do something to help them. But then we had to go through recruitment. So that being an outer suburban hospital, it was a little challenging. Obviously not as challenging as the rurals would experience, but for us it was to get to that level. And the final thing that we did this year was we expanded our inpatient services, and we've got a lovely new building up the front, which was on the picture of Werribee Mercy earlier. And in that building we put some more operating theatres, we added 56 inpatient beds, and we opened an ICU. With opening the ICU, we had quite a significant change in our patient population come on board, because we now could take higher acuity patients that we previously were shipping out. So it was a whole of hospital change where our wards and our emergency department were now getting different patients and more of them. So in the increases in the emergency department presentations, it was very evident that they were the higher acuity ones. All of this you'd expect to have an impact on our NEAT. It did, but not as much as one might have suspected. So the blue line is the overall NEAT for Werribee Mercy, and the green line is the presentations. So we have maintained and slightly improved our NEAT performance in spite of all the demand we've been experiencing. So as an organisation, we're really proud of what we've achieved. And we've done this by looking at it as a whole of hospital and a focus on our flow, because it is not just the emergency department, as I'm sure all of you are aware, that influences what the NEAT will be. It's actually what happens across the organisation. So we were very fortunate to be part of the Emergency Access Collaborative in 2017 and the Patient Flow Partnership in 2018. And why I think this was so fortunate for us is it gave us the opportunity to see what other organisations were doing and to learn about what options we might have for changing our patient management. We've taken on board a lot of those, and we've looked at 5 particular streams of care. So we've looked at our admission process, because how do we get a patient accepted and into an inpatient ward from the emergency department was an area where we saw we had some concerns. We've looked at our patient management flow, so the DOS system. We've spent some time in the emergency department with how they function, and also our higher acuity patient flows throughout the hospital, which was really important in the context of opening that ICU. And the final area is discharge processes. You can't bring a patient in if you can't get them out at the other end. So it just stops everything. We've got a bit of work to do there, but we'll just quickly run you through each of those areas and what we actually did. So the first thing we did in our model, we have a lot of sessional consultants who are not on site in both medical and surgical teams. So how do we get a patient accepted for admission was often one of the biggest barriers to why they would spend an extended time in the emergency department. We engaged with our senior clinicians and we spent some time working through flow and getting them to understand the patient's perspective was really an important component of that. So if the cubicles in the emergency department are blocked with patients waiting to go to a ward or to be seen to be accepted to go to a ward, that means all the patients waiting in the waiting room that we don't know how sick they are and how potentially they're getting worse, we can't see them, we can't address that. So we kept bringing it back to that and what is a patient's experience. It was a really good piece of work to do and our senior clinicians engaged quite well with that. And we got an agreement to work through a process that's up on the board. A critical component of that was an escalation process and it has been quite interesting to watch the uptake of the escalation process because everyone's a little worried, particularly overnight, that they don't want to ring anyone. So patients were staying and waiting till the morning because no one wanted to ring and disturb someone, even if they were supposed to have been on call. So we've been doing some work on changing that, that mindset so that it's not about the clinician is on call and that it's okay to ring them and that we can escalate to the senior staff when we've got barriers and blocks. We have seen an improvement. We do need to do some more work there. We've also looked at communication because at the end of the month when you put your figures up, it's probably a little bit too late to be able to look at why things are perhaps not going as well as they are. You would want them to be. So we've developed a report that goes out each day. It's an automated report where we have a dashboard dial that tells us what our need was. We break the need down and we also look at 4 key areas of where we can make a difference. So from arrival to first seen by a doctor, from first seen by a doctor to referral to an inpatient unit, from referral to when the patient's accepted for admission, and then from acceptance to when they leave the department. And so we break that down so we can then put some strategies in place and see where our barriers are. We've got a little bit of work to do on the data collection. It's not because not all of those times are automated, but it has really opened everyone's eyes to where we need to work and helped with the senior clinician engagement. We've done lots of talking at managers forums. Our CEO's been engaged and has sent out a memo talking about people's responsibilities and the patient's needs. And we've also spent time in our performance meeting trying to dissect what we're doing and what we could do better. In the emergency, we've implemented some changes in staffing. So we've looked at an AV nurse, we have one, and that's how we managed to improve our off-stretcher times. We're currently sitting about 85% and we've been struggling along at that rate despite the increase of ambulances by about 200 a month over the last few months. We're now averaging 800. We've talked to the ANUMs and worked with the ED ANUMs about their roles and responsibilities. So what was taking them away? What were the tasks they were engaged in that was taking them away on focusing on flow? How were they able to facilitate if they're off making a bed somewhere or having spending some time with the ward staff with a handover. So getting their role back to purely being about patient flow, addressing patient needs and keeping the emergency department running. We've encouraged a real sense of achievement. It became almost a little bit of a game of how good can we get the NEAT today? And we've supported that because then that's about getting the patients moving through. On the triage screen, we didn't have any prompts. So when, for EDIS, which is our patient management in the emergency department, there was no prompts about time. So we've added in some visual management with some colour coding. So the orange is patients at 3 hours to give them that, yep, we need to get moving. Why is this patient still waiting? What can we do now? We've then, red is when they've exceeded their 4-hour stay, but we've added in purple, and purple is a 12-hour. It's often about they're in short stay and they're still coming up, but it also gives them the opportunity to look at those longer stayer patients that we still might be looking for transfer out or something of that region, and letting the ANUMs know quite clearly that this patient's been here a long time now. We really need to escalate this. And they've found that quite helpful because at a quick glance they can see what's happening. We've done some work with our short stay and fast track pathways to facilitate a more prompt transfer into both of those areas from the triage desk. So we do have a couple of pathways where patients can be directed directly to short stay from triage. And usually if they're outside a pathway though, they have to have a consultant approval for that. The daily operating system we saw as a fairly significant piece of work, and we've looked at it as a very simple statement of, are we ready for today, and if not, why not, and what are we going to do about it? So we implemented that about 3 months ago. It's a 3-tier model where we have the ward huddle, we have a huddle where all of the information comes together, and there's an executive huddle that follows if required. We've been doing a lot of work on that. We've still got a long way to go, but we've moved from a purely bed management focus to asking questions about what else is influencing the flow of patients and the ability to provide care throughout the day. We are hoping to have a redesign of that ready to go next year, with a little bit more focus on the delving into those problems and particularly around discharge barriers. Once we have it quite well established, we will then be moving it over to Mercy Hospital for Women. With opening an ICU, we really significantly changed the flow of the acutely unwell patient within the organisation. So prior to the end of August, because we took a little while after opening ICU to transition, the ED was our emergency response system in Werribee Mercy. So if there was a Met call or a code blue, the emergency staff would take off down there, which was hugely problematic with being able to keep care of the patients in the ED going. The ICU and ICU liaison group since opening have taken over this role, but it was also about understanding how do we get those patients in and how do we refer a patient from ED, from the wards, from theatres, to get them promptly moved so that we can then utilise the space where they currently are. We're looking at an electronic version. It's being developed up by our teams, but the ICU director has taken real ownership of this and is working with all of the other heads of department to make sure we have a prompt responsive system as well. We have a monitored beds area that sits outside of the ICU. We always had that, and there was always some concern about how that was how you got patients in and the egress of patients out of that area, and they would often go in there and they would stay there for a long period of time because the physician or the surgeon wouldn't be quite knowing when they should stop the monitoring component. So now we have the ICU engaged with that as well, and we're including that as part of our higher acuity referral process. Finally, discharges. I mentioned earlier that you need to have good flow out of the hospital to be able to put patients through. So we want to do a lot of work, and a lot of what we've seen happening throughout the patient flow partnership are the sorts of things that we want to implement. We have a quite challenging medical model where our consultants are quite, they're sessional and they're not there all of the time. So often the rounds to look after the patients will happen later in the day, which doesn't help your flow when we know the emergency department peak is in the afternoon. So for us, it's about how do we change that. So we've put some more junior medical staff in place. We've increased the amount of registrars we have on all shifts, and we've looking at the work practices and flow of the work for the junior medical staff. And coming up shortly, we'll be starting where the consultant will be required to be on the round at 8 a.m. for handover and then do the post-take round in the morning. So that's a really exciting piece of work for us, and it's helping us move from where we were at the small community hospital into a proper metro heading towards a tertiary hospital. Has this achieved anything for us? We believe it has. Our NEAT has improved a little bit despite all of our big demands. We've also, the slide here shows quite a number of improvements that we've achieved over this year in times for patients. I was very disappointed to see that we've still got a red arrow, and it is our readmits. We are looking at that and what we're doing about it, and we have implemented this year that if a patient represents a second time, they have to be seen by the consultant, so that there is a clear, let me have a little bit more of an in-depth look at this process. The mental health patients, you'll note, have dropped. They're greater than 24-hour stays. We have quite a large mental health program associated with Mercy, and our ED would often have lots of patients waiting to be seen. The mental health program itself has implemented a bed management system that links into our DOS quite nicely, because they also have the emergency department at the Footscray Hospital in Western Health that they oversee mental health patients for. And it's about managing those competing demands for very few mental health beds. So lots of work's going on for the mental health patients as well. I particularly like the figure for the did not waits. They have dropped significantly, and that's really reassuring and something that we're going to keep our focus on to make sure that they continue to go down. And I think this graph was put up by our service improvement people as part of the patient flow partnership work, and I really like it because it shows quite clearly the significance of opening our new area and what the change when that happened did to us, where our really good achievements in NEAT dropped right off. We can't forget the patient in this. So another area that for us was really important to manage as we went through all of this change was the patient's experience. So looking at some of the feedback we were receiving, we were getting lots of complaints about communication and the wait times, and also about our VES comments were really clear that we needed to focus some time in the waiting room as well. So coming up shortly, we will be implementing a rounding process in our waiting room to help facilitate this. But we also have recently put dashboards up, and we've done it at both of our hospitals' emergency departments, that show the waiting time, but also there's some screens that scroll through what to expect in an emergency department and try and explain the processes that people will go through. Things like, what does triage mean, and why are there different categories, and why you might wait longer than someone who's on a different category. So that's a real nice piece and one of my favourite pieces of work. We've come a long way. We've climbed mountains, but as you can see, there's still a lot more mountains for us to go up, and we are looking forward to what further achievements we will have with the continued planned improvements we have ongoing. So our values are important, so they're there, and I would like to thank BCV in particular for the opportunity to be part of the Patient Flow Partnership, and acknowledge all the staff at Werribee Mercy and what they've been experiencing and how they've come through, and it's really exciting to be able to showcase our improvements this year. Thank you very much.